Hi, this is Brian Kim. I'm going to share with you case number 46 and the best way to do cataract surgery series. This is a small pupil, and I'm going to show you how I'm able to use double chop, cross chop, and mechanical fracturing. And in my opinion, the safest and most controlled way to disassemble the lens in a small pupil. Some would disagree and feel like you have to have a big pupil using hooks and rings, but with this technique, I feel very confident you don't need these instruments to perform a very safe and effective lens disassembly. So I'm going to use a corneal marker to help me center and size my rhexis and make my paracentesis incisions inferiorly and superiorly, make a flat approach with my blade to get a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some intracameral epinephrine to see if it can open up the pupil. It doesn't seem to open it up very well. And then I'm injecting some dispersive viscoelastic into the anterior chamber to viscodilate the pupil. And then I do my triplanar corneal incision. I make a vertical groove, place the blade into the deepest part of the groove, tunnel through the cornea, and then dive down. I use a cannula to help control the eye as I do these maneuvers. I go in with my capsule forceps, puncture centrally, pull downward, and then grasp the right edge of it to create a flap. And in this case, the pupil size was about the size of the corneal marker for my rhexis. So I'm going to use the pupil to basically go around circumferentially for my Capsulorhexis. So finish off the rhexis and then burp the viscoelastic. And then this is the Capsulorhexis hydrodissection technique. Place the cannula out underneath the anterior Capsulorhexis edge contra-incisionally. I'm pushing BSS and get a nice fluid wave. Go out, decompress on the left side, and then go onto the right side, pointing the tip down and rotating the lens quite nicely here. So I'm irrigating the surface of the eye, making sure the sleeve is the right length for my technique. And then I use a chopper to lift the incision, go in with irrigation off to minimize Descemet's trauma. And then I'm going to remove the surface epinuclear material and do the double chop, go underneath the epinuclear ridge out to the equator, turn the phaco tip vertically, subincisionally, crush the lens in half, bisecting it. This is the double chop. Place the chopper out to the contralateral equator. Pull the chopper centrally towards the phaco tip. This crushes the right heminucleus. This is the cross chop maneuver. Using some vacuum, I'm able to pull that first quadrant up and then crushing it and then emulsifying the lens piece. I place the chopper out around the second quadrant, pulling it up out of the bag and emulsifying it completely. Use a chopper to turn the second heminucleus around in front of me. Place the chopper underneath the anterior Capsulorhexis edge out to the equator, crushing it against the phaco tip. This divides that second heminucleus. I'm able to emulsify that third quadrant. It just came tumbling out towards the phaco tip. This is the last quadrant. I place the chopper around the lens piece, crushing it against the phaco tip, and then emulsifying the lens pieces. I'm trying to use a little bit of vacuum to encourage that lens piece up, and then I push the epinucleus off with the chopper, emulsifying that final fragment. Now I'm removing the epinucleus in a separate step here. There's still quite a bit of epinucleus subincisionally. I'm trying to carefully remove it with the phaco tip. This is where I'm wondering, maybe I should just switch to the INA, but I'm just manipulating the lens material and then using the phaco tip to remove it. I take the chopper out, push BSS in, take the phaco tip out, and then switch it with the INA handpiece. I start subincisionally, removing the cortical material from the anterior side. Sweeping side to side, I'm trying to peel the cortical material off the capsular bag, and I'm going around circumferentially. Because the pupil is small, I'm switching to the polish mode early, making sure that when I get underneath the anterior capsulorhexis edge, that I don't snag the bag and pull the zonules and stress the zonules. Remember, when the pupil is small, you have to think about zonular weakness as a cause for the small pupil. And so I like to go into polish mode and very carefully but confidently sweeping under these low flow parameters. I polish underneath the anterior capsule rim as well as on the posterior capsule surface, where I'm able to see any remaining lens material. Try to remove every visible remnant of lens material off the posterior capsule surface. I push BSS through the paracentesis into the subincisional capsular fornix area. It looks pretty clean. And then I push some cohesive viscoelastic to inflate the capsular bag and anterior chamber. And then I'm using the capsule sweep. I want to inflate the eye as much as possible so that the iris is off of the anterior capsule surface. I sweep on the left side first and then on the right side. Inject the single piece acrylic lens into the capsular bag on the leading edge. And the trailing edge is still in the anterior chamber. I'm going to go in with the INA handpiece, inflate the eye, which helps to cause the haptics to disassociate from the optic. I'm using the Maltzman to ensure that the lens is completely within the bag, including both haptics. I get underneath the lens and rotate it 90 degrees clockwise, and you saw I was able to tilt it with the help of the Maltzman. I switch to the visco mode, removing all the viscoelastic from the anterior chamber, and I'll use that Maltzman to help make sure that the lens is completely in the bag. I push BSS into the angle to remove any potential remaining viscoelastic material. Take the INA handpiece out and then hydrate the incisions. And so you can see this is a somewhat of a small pupil, but by adhering to mechanical fracturing techniques, using the chopper to crush the lens material against the phaco tip, making sure that both instruments are within the capsular bag, which means you are underneath the anterior capsulorhexis edge. With all these maneuvers, this is a very safe technique. You can be very confident in what you're doing. Certainly, you can use pupil expanding devices, which you would need for other techniques where you might be sculpting using high vacuum, cracking, etc. And if you're not really careful with those techniques, you can cause a complication. Thankfully, with this technique, it is really not dependent upon some of the visual cues as traditional cataract techniques. And so this is really a much more versatile way to do cataract surgery because you're able to use a chopper to get into the bag, crush lens pieces, and pull pieces up out of the bag. So I hope this was helpful to you, and I thank you for your attention.